Children's Hospital of Philadelphia, where she serves as the Vice Chief of the Division of Genomic Diagnostics, and she's also the Director of Genomic Diagnostics. And ready for your talk.
Okay, thanks, Dr. Gass, for the introduction. I also want to thank SERGG for inviting me here. I used to be, I should say, I'm still part of SERGG. I was at Tulane for over 10 years, and I came to this meeting every year. So I'm so happy to be here and to see all of my old friends and also meet new friends. So next 40-ish minutes, I'm going to share our experience in how we use integrated multi-omics profiling data and to inform precision cancer care. As we know, cancer is a multi-omics disorder. For any cancer to happen, they would have been multiple different aberrations, and that can happen at different level. It could be genomic level, transcriptome level, or epigenomic level, or metabolome, or protein level. So those aberrations, it's going to either activate oncogenes or inactivate tumor suppressors, or both, and that will lead to the 6 hallmarks of cancer. So because cancer is a multi-omics disorder, so the cancer multi-omics diagnosis should use multi-omics approach as well. So in our laboratory, and which is a comprehensive cancer diagnostic laboratory, we use chromosome analysis, we use FISH. Those are older technology, but they are still standard of care. And we do copy number variations with microarrays in some cases, not all the cases. We also use single gene or single mutation approaches when that is necessary. For example, when you meet a pseudogene, and you may need to do long-range PCR, and that what you use, you will have to use the MLPA for copy number and use the SERGG sequencing for mutations. We do offer personalized test, which means we design this test only for that patient because only that patient had this biomarker. We also offer pharmacogenomic testing focused on the variants that may indicate patient tolerance to chemotherapy. This could be isolated test, and or that is if you order our next generation sequencing panel, that is integrated into the panel. Last, certainly not the least, and you see I have 4 different pictures there. It's multi-omics testing. So we do offer testing a large next generation sequencing panel put together about 500 some genes. And we do tumor-only testing as well as tumor normal paired analysis. So if there are cancer predisposition, we will know right away after sequencing when do tumor normal paired analysis. We offer transcriptome sequencing, whole genome, whole exome sequencing for cancer. We also offer methylation analysis for certain diseases, for example, brain tumors, sarcomas, and we are going to launch a liquid biopsy. Our first test is going to be in neuroblastoma, and NF1 is going to follow, and a pan-cancer liquid biopsy, and it will be the next. We have a small scale of protein omics study, and at this point it's not large scale as of yet, but that is in the pipeline to be developed. So this slide I always put it there because the panel testing is still and the most commonly used tested because of the cost and the short turnaround time. And in 85% of the time, you are going to get the right diagnosis. So we design our own panel. as what you can see, there are two different parts of this panel. So first is on the DNA side, and we use adjuvant serial select. We design our own panel. It's pretty much pediatric geared, but and we include all adult components. And the main reason for that is we do see patients who start from pediatric cancer and then move on, and they still come back to see their pediatrician. Within that, and not only we cover the region of interest, and which would be the genes of our interest, the flanking region, promoter region, enhancer region, or no intronic mutations. All of those are covered because we design ourselves. We also put in SNPs for ID, for copy number change analysis. So this is going to help you to identify ploidy changes. So not only deletion duplications, but also is that genome triploidy, hypodiploidy, or near haploid. We put in 16 SNPs for ID testing, which is super important. Next generation sequencing, you pull all the patient data together. When you demultiplization, you want to make sure and the data you analyze is from this patient. So this 16 SNPs are tested separately, and one is through next generation sequencing, the other is through the TACMan real-time PCR testing. And then we bioinformatically meet them together. If it's a match, we know that's from this patient. If it's not match, immediate and trigger troubleshooting. So that could be bone marrow transplant or other reasons, or library mix-up. So on the RNA side, and we use ENCODE multiplex PCR. Now many people use that. It's like a one-sided PCR. As long as this specific gene is targeted in your panel, and it will identify any translocation patterns. And with that, for example, KMT2A, also known as MLL gene, has over 100 different translocation partners. So we only target KMT2A. Any translocation with any other genes, as long as it's with KMT2A, we will be able to pick it up. So, and this technology also allows us to molecularly tag each of the targets, and this will give us a code for specific variants, and that allow us to use just the 3 reads and to mark specific new fusions. As you know, you have a panel of 500 genes, or you do exome sequencing or genome-wide, whole genome sequencing, you're going to have numerous variants identified. And even for 500 gene, you're going to have probably 500 variants in your final output VCF file. So, and that takes a lot of time for your analysts to go through. So after we run a few hundred cases, we decided to use machine learning technology to trim down the work need to be done manually. So what we did is you first use a principal component analysis to identify what are the features, and that will distinguish a true variant versus false variants. So we use 3,300, more than 3,300 variants that is humanly analyzed, and to identify what are the features, and that is important. And then we come up with this proof of concept classifier. After that, we do a validation with another 2,300 different variants to fine-tune the classifier. Finally, we'll identify one of those as the winning classifier, and then validate that with additional 5,600 different variants. And those were in parallel with human analysis, even though we did put in a lot of time. But after we finished the project, we were able to eliminate 97.3% of the variants that without this AIQC project would have to be reviewed manually. And that saved 50% of the time of analysts. So that allowed us to do large cohort of study. So you will still, for 500 a gene panel, you will still end up with somewhere between 15 to 30 variants, and that you need to classify them. And we use the AMP, ASCO, and the CAP guideline for somatic variant classification. Variant are classified based on the evidence. So tier 1 and tier 2 are variant with clinical significance. The stronger the significance and the higher the tier. And any variants that is not cancer associated and might be with relatively high minor allele frequency in the general population would be deemed as benign or likely benign. And then anything not fall in tier 1, 2, or 3 will be variant of unknown significance. So this is our first summary, and we did a few years ago before pandemic. After we ran 367 pediatric cases, we did a summary, and we identified close to 80% of the cases we will have clinical impact for return. And out of that, about 72% with diagnostic significance. At the time, about 3% actually changed the histological diagnosis. About 50% of them with prognostic significance, which means you can use that to stratify patient risk and to determine how you're going to treat those patients. And about 45% of them and with therapeutic significance. We did a QC study with Cancer Center. We found out of those 45%, 36% changed the treatment based on the prognosis, about 12% that provide patient with potential targeted therapy. Last not least, is the potential germline variants. And at that time, and because that cutoff was 2017, we will not offer tumor normal paired analysis, so we only call those presumed germline pathogenic variants, and then refer to our cancer predisposition program for genetic counseling and additional confirmatory testing, and that is close to 20%. At the end of 2021, that's about 1.5 years ago, we've run 3,688 cases, and the positive yield is still about 80%, as what you can see, but the largest change is more than 10% of the patient, and we either changed or redefined the diagnosis. The reason for that is, and for anybody who is doing cancer, you know, WHO guideline continuously put in more of multi-omics marker, not just genomic, but also maybe methylation status into the professional guideline. That's why this diagnostic yield increased drastically. So now I'm going to use a few examples. I think the example is very convincing evidence to show how multi-omics study can inform precision cancer care. So this is an 11-year-old boy with high-risk pre-B-cell lymphoblastic leukemia, and we know the patient because of the age, because of the white blood cell count, the blast count. We know it's high risk, so the patient is on COG, very high risk standard arm A. It's a phase 3 clinical trial, patient is on. On day 8, patients still have 43% of blasts. On day 29, which is the end of induction, still 40% blasts. Patient is apparently not responding to the treatment. Look at the findings in the laboratory. Cytogenetically, I'm not even going to try to read this out. Complicated chromosome abnormality, that means poor risk. But it doesn't really tell you how you're going to treat that patient. because of chromosome 9 abnormalities, so we did, I want to show you how we eliminated, this is not a BCR-ABL positive ALL. And then we did a microarray, and this is late 2015. I just moved back to CHOP. I don't have my panel ready yet, because my panel launched 6 months later. So you can see the microarray. This is chromosome 9, and with chrome trypsis. I want you to focus on this little tiny where the arrow shows. And if I enlarge this, and this is a part of JEC2 gene duplication, which is proved by FISH. You can see there are 2 normal JEC2s, and there is extra 3' of JEC2. When a gene is partially deleted or duplicated, you should always suspect there's a fusion there. So we tried, and at the time I was validating our next generation sequencing panel. So I put this patient's RNA into our fusion panel. This is what we identified, a GALG-A5 JEC2 fusion, which had never reported before, and I think this is still the only case reported as of now. So we certainly SERGG confirmed that, and in my lab, any new fusion identified the first time in our lab will SERGG confirm that, at least for record. So you can see, and this fusion combined the GALG-A5 coid-coid domain to the kinase domain of JEC2, and that is going to activate JEC-STAT pathway. So this patient, we immediately add ruxolitinib, and which is a JEC inhibitor, to the patient treatment. In the meantime, we just designed a real-time PCR assay and look for the transcript of this fusion. As you can see, when the ruxolitinib is added to the treatment, you see the transcript drop drastically, and the second month and the third month is undetectable. Basically, it's the baseline. And in the meantime, and this patient was, the bone marrow was put in NSG mice, and we bled the mice, and after the injection for a period of time, and look for the leukemia engraftment. And then we sacrifice those mice. And we treat those mice, and we randomize the mice. Part of the mice is treated with a vehicle, the other part of the mice is treated with ruxolitinib, and then we sacrifice them, and we look for in their blood, and as you can see, and treated with a vehicle, and the blasts continue to go up, and treated with ruxolitinib, and you see the drop of the blasts. And the same is true in the spleen. And as what you can see, the leukemia load in the spleen on the vehicle is very high, but with ruxolitinib treatment, and it's basically undetectable. So this patient, after the patient reached the complete remission, we put the patient on CAR-T therapy, and then the patient had a complete match sibling, so he went through the bone marrow transplant. He was 11 at the time of diagnosis when he was 12, and that was the bone marrow transplant did. And right now he's a sophomore in college, he never relapsed. And I always think about this patient. I said, if we never find this fusion, what's going to happen to this patient? So next one, I'm going to talk about how important the cancer genomic diagnosis. It's not isolated laboratory diagnosis. It should be a multidisciplinary diagnosis. This is a patient who was born with a huge tumor on his right side of the lip. And you can see the right narrow, the nares is completely blocked, and he could not suck milk. And it was originally concerned for vascular anomaly because it's so blue, but the ultrasound showed this is really a mass and with internal bleeding. And so a biopsy was done for this patient. Unfortunately, histological diagnosis was not clear. So I was told the most consistent diagnosis would be infantile fibrosarcoma, and I was looking for NTRK fusions and anything associated with RAS, MAPK kinase pathway mutations. So our NGS panel was not informative. So at that time, and I went back to talk to the pathologist and oncologist. So what could be the differential diagnosis, which is so important in that case? And they said, well, it could be cellular myofibroma or infantile myofibroma. And so I said, okay, so let's do RNA-seq for this fusion because that was not included in the panel. And look for PDGFRB and Notch3 variants. So this is a lot of manual work. And the reason for that is, NGS analysis has a drawback for indels. So when it's not a match to the normal, and the allele fraction is going to drop, our detection limit is 5% in general, 3% for any variants we've identified before. So we do bioinformatics and you have two different levels. So this is what we found. In the PDGFRB and with the exon 12, this is exon 12, we found a few reads somewhere between 1.3 to 3.5%, which is below our cutoff. And it's a large indel. And I also find a reciprocal breakpoint. And in the intron of the PDGFR intron 11. So this is, of course, Sanger confirmed. We ran the Sanger, and this is, we use a nested PCR. You can see this is outer primer, and this is inner primer. The 5' forward primer is shared, and we identified this is where the breakpoint is. So, and it's a large indel, and it's also inverted. This doesn't really tell you that allele is expressed, right? So we went to see if PDGFR is expressed, it increased the expression, or if it is, which allele is expressed. So what we found, and for sure, PDGFRB is overexpressed compared to any of the solid tumors in our cohort, and compared to pen cancer, both increased 20 to 40 times. And the increased expression is this variant and the allele with that inversion. So this inversion is large. It includes 84 base pair deletion and the 90 base pair insertion. And from this, and we made the diagnosis, and this patient had infantile myofibroma instead of infantile fibrosarcoma. And because PDGFRB, we have this famous Gleevec, and most of the patients with this mutation will respond to that. So this patient is put on Gleevec targeted therapy. I blocked the patient face because it's not published. And this is 1 day after biopsy. You can see that. This is 1 week after Gleevec treatment. This is 5 weeks after Gleevec treatment. This is 8 weeks after Gleevec treatment. Patient never had surgery, never had radiotherapy, never had any chemotherapy. It's drastic. And our analyst went back to check all the patients with the same diagnosis. We identified another patient which actually was referred to us from St. Jude. We tracked it down to that patient, and that patient now is on treatment. So it is so drastic how a right diagnosis can change the patient outcome. So this case, I want to show you how important the multi-omics study is. So this is a 8 weeks old infant boy, and as you can see, there's a huge mass and from the image, and certainly the diagnosis is, brain tumor is clear, but what type of brain tumor was not clear, and we only call that poorly differentiated high-grade infantile or congenital tumor because it's 8 weeks. So, and we did our next generation sequencing, which was not informative, so we did transcriptome sequencing for that. So we identified this ataxin-1 new TM2A fusion, and as you can see here, that caused by chromosome 6 and 10 translocation. And then this was what we called this patient at the time. I said, well, I can only call this patient with CNS sarcoma with this fusion. But how bad, how good this fusion is going to lead, the outcome of this patient. So I look at the expression profile. And what is interesting is we see ETV145 and W1 overexpression, as what you can see here. This is this patient. We also have another 2 cases, one CNS tumor, one tumor of unknown origin. So we ran the methylation analysis for this patient. What you can see here, and this is a T-SNP plaque, and which group different brain tumor together. And if I enlarge this, and this is group with sick rearranged sarcoma. And we know sick rearranged sarcoma is poor prognosis, so we know those patients, and they're not going to have good prognosis. And why ataxin-1, and one of the fusions with ataxin-1L, and they behave like sick rearranged sarcoma. We did a bunch of literature research. We found out ataxin-1 or ataxin-1L, and they bind with sick protein, form a transcription replacer, and any alterations that reduce either sick or ataxin-1, ataxin-1L will reduce the transcription replacer that will lead to downstream gene overexpression, and that's why they have similar gene expression pattern. So we certainly published this right away, and this was probably the quickest publication within a month that got published. And we proposed altered sarcoma, which is WHO guideline code, and probably it is still called sick rearranged sarcoma, probably should call sick altered to include other aberrations. And we also see the 3 patients, they're all congenital, and they all have very poor prognosis. We're not sure whether ataxin-1, ataxin-1L associated fusion will give poor, even worse prognosis to those patients compared to sick rearranged one, but our N is too small. So far, we only have 3. So this is the last case I want to talk about, and this is, I want to explain how important in pediatric cancer, the germline cancer position is going to play a significant role, and especially in the genetic ward. So this is a 7-year-old boy with no prior medical history, and he came to us with 1 week left side weakness, and image showed a right side mass in the brain, and it was diagnosed with right synamic mass. So we did a biopsy. I got a piece of the tissue. The diagnosis was pretty clear, and it was a high-grade anaplastic astrocytoma. And we did our next generation sequencing analysis. First, we identified this H3 mutation, so this is diffuse midline glioma. The diagnosis is pretty clear. What is striking is here, and there are 2 variants, and they're about 90%. What I didn't show here is there is an MSH2 loss of heterozygosity and copy number neutral loss of heterozygosity, and there is a deletion of 17p. So could this 2 variant germline? So that's what we need to figure out. And you can see this is a hypermutated tumor as well, which has some treatment indication, but that's not what I'm going to focus on. I'm going to focus on cancer predisposition. So this patient was referred to our cancer predisposition program for genetic counseling, and you can see came back. We first, I can't really see very well. So first we identified through the genetic counseling the maternal grandfather had Lynch syndrome, carried the same MSH2 mutation, and so that is likely inherited on the maternal side. And then when we look at the paternal side, and we found, well, first we did confirm both of those variants are germline, and then you can see there is a maternal uncle who had testicular cancer in the 20s. And then on the paternal, and that's paternal uncle, and on the paternal great grandfather and grand uncle, and you can see they all have cancer, colon cancer, prostate cancer in their 50s or 65. So it looks like leaf-limiting, and in this side of the family. Not surprisingly, and we did the parent study, the TP53 variant is from the father, and the MSH2 variants from the mother. And the patient does have a sibling, and the younger brother carried the MSH2 variants. It is important at this point, and this child, right now it's still healthy, is under surveillance right now. So with all of this, I want to say integrated multi-omics profiling provide clinically impactful information, and that can help with diagnostics, prognostics, and therapeutic decision-making. And clinically significant variant are found in 80% of the patients, and at least 40% in 40% of the cases that can inform the therapy. But a correct diagnosis is going to lead to correct therapy as well. I think integrated multi-omics profiling should be provided to all pediatric and adult cancer patients to inform precision cancer care. This is what we are trying to do. We're going to have a program using the philanthropic money to offer the test to all patients, regardless they have insurance or not having insurance. We understand there are significant challenges present. I allude a little bit. Is insurance going to pay for that? How you're going to survive in current payment environment? And there are bioinformatics challenges and technology challenges. But I do think if we collaborate, with each other, and especially I think this is going to involve not only laboratory professionals, but also oncologists, pathologists, and the genomicists. And if we will collaborate on education, standardization, and I can't stress enough about data sharing, and also certainly artificial intelligence, and we can reduce the cost and bring the benefit afforded by the new technology to our cancer patients. So with that, I want to acknowledge all the people at the Division of Genomic Diagnostics at CHOP, and certainly our oncologists, the pathologists, our patients and parents, and certainly the funding and all the donors to our program. And thank you for your attention. I'm happy to answer any questions.